I was diagnosed with kidney disease in 2016. The impact, of course, was huge. I had to be in hospital quite a lot. But when I came home with home dialysis, life normalized quite a lot. I could go to work, I could continue my hobbies. Life is much more normal now.
Home dialysis is dialysis treatment that the patient is performing at home, and we have been opted for that strategy for more than 20 years. We have about 35 to 40% of our patients doing home dialysis.
I think the kidney center staff is excellent. They have treated me very well, and all the training I have had. It's always easy to call them and they will help me.
The kidney center in Turku is a very supportive working environment where you have the possibility also to progress professionally and the possibility to do clinical research.
This is quite international. We have a lot of international students and young researchers, and we are also producing quite a lot of research and publications, PhD degrees as well.
We have a very innovative and open atmosphere. It makes everyday work very interesting.
It's a pretty nice size of a center, so we all know each other, so it's a nice place to work, therefore we have a good spirit here.
Turku is situated in the southwestern part of Finland. This hospital district has about 500,000 people whom we are serving. This is a small unit. We have to do everything that modern nephrologists do. We give dialysis, we take care of the transplant patients, we do kidney biopsies, and we have a ward here. We try to give the best of nephrological care based upon sound clinical judgment and analytical research. We have clinical research mostly. We do follow-up study of pre-dialysis patients, which we call the CKD. It is cardiovascular disease in kidney patients. We look at the cardiovascular risk factors. We have about 2 years follow-up data, so we will be able to do some publications very shortly.
I'm professor of metabolic research at Turku PET Center. We're doing here thousands of imaging studies annually. Personally, I enjoy a lot working with Kidney Center.
Our cooperation with the PET imaging center is about 15 years old.
PET is the only way we can non-invasively evaluate kidney perfusion and kidney metabolic events.
As chronic kidney disease progresses, almost all patients will develop abnormalities in the bone metabolism. Bone and mineral disorder is a disturbance in the mineral homeostasis that leads to trabecular and cortical defect in the bone. And we call this renal osteodystrophy. Renal osteodystrophy is hard to diagnose. We believe that positron emission tomography could be a new non-invasive diagnostic method. In our research, we have compared the PET scan and bone biopsy and the histomorphometric markers that you get from the bone biopsy to see how well these correlates with the trace activity in the PET scan. So far, the results are really promising.
We are part of this multinational IBEAT study, which is trying to develop new imaging biomarkers for diabetic kidney disease. In this IBEAT study, there is 5 centers: Leeds, Exeter, Bari, Bordeaux and Turku. We here in Turku are trying to validate the PET perfusion against MRI perfusion. I really hope that we will find a new imaging biomarkers which could replace the need for kidney biopsy.
I am self-endocrinologist and diabetologist, and it's extremely exciting to find joint efforts and focuses with nephrologists. SLT2 antagonists are working very much via kidney and seems to be quite promising for type 2 diabetes and also to prevent cardiovascular deaths.
Kidney diseases are becoming more frequent. In the future, we will need more nephrologists. Our aim is to encourage young doctors to specialize in nephrology.
I'm a specialist in internal medicine and a resident in nephrology at the kidney department. I think nephrology is maybe the specialty where you go deepest inside the real issues with cardiovascular medicine, and that's what attracted me. Since nephrologist patients don't die of kidney failure anymore because we have nice active therapies like dialysis and transplants, cardiovascular disease constitutes the major cause of mortality and morbidity with these patients. We are doing research with cardiologic studies in nephrologist patients. We are trying to find out what the reasons behind hemodynamic instability could be, other than just cardiac disease, which is one reason.
We have been using the National Registry of Kidney Diseases in Finland for more than 30 years to compare our results with other